Okay. Hi, everyone. We'll just give it a couple of minutes while everyone jumps in. All right. To keep us on time, we'll get started. Hi, I'm Catherine Bennett. I'm the Head of Marketing and Communications for EBOS's institutional healthcare business, which includes the HPS Pharmacies network. So welcome to this HPS Pharmacies webinar lecture. These are educational presentations that can be used to contribute to your CPD hours to meet the standards set for professional registration purposes. You might see in the corner of your screen that we are recording this lecture for on-demand playback, and notes will be available by emailing us following the event. A prompt to do this will be sent to you within 24 hours, so keep an eye out for that, or you can email us directly. Now it gives me great pleasure to introduce our speaker for today. Her name is Tran. She's a clinical pharmacist at HPS Pharmacies Ashford, who will be discussing common medications for end-of-life care. Our agenda will allow for 5-minute Q&A at the end. If you navigate to the bottom of your screen, you'll see a little Q&A button. If you can type your questions into the Zoom interface at any time during the presentation, we can respond at the end, or I can open up your microphone and you can ask the question of To in person. So we hope you enjoy this presentation and find it useful for your practice. I'll now hand over to To. Thanks again for joining us.
Thanks, Catherine. Hi, everyone. Welcome to HPS Pharmacy webcast lecture. My name is Tran. I'm currently working as clinical pharmacist at Ashford Hospital. Attending this section can be used to count toward your CPD point for the purposes of professional registrations. This webcast, we will focus on common medication for end-of-life care. That is a care that people receive in the last years, months, and weeks of their life. Can help to minimize the distress, grief associated with death and dying for the individual and for their family, friends, and carer. In end-of-life care, symptoms of discomfort are mainly managed by drug therapy. The guidelines for which are mainly based on expert opinion and is tailored to individual patients. Most of the information from this presentation is general and based on recommendation from the therapeutic guideline, palliative care. There is a limited evidence to guide medication use in the last days of life, and practices may vary between healthcare facility. The therapeutic guideline promotes some of these key principles. Continue current medication if needed for symptom control. Administered medication via most appropriate route, often subcutaneous or sublingual. Cease medication that are not required for symptom control or which are burdensome, including anti-diabetics, lipid-lowering drugs, antihypertensive, or anticoagulants. Anticipatory prescribing is encouraged for the timely management of possible new or worsening symptoms. Medication should be used as required for intermittent or breakthrough symptoms and prescribed regularly for ongoing symptoms. The dose and frequency should be adjusted as required based on patient responses. Considers potential reason for non-response to medications. For example, syringe driver not working, dry mouth, affecting absorption of sublingual medications, or whether the current dose is sufficient or additional medication is required. Considers practical issue associated with subcut drugs, including, injection volume or drug compatibilities. If the patient distress continues despite adequate doses of drug therapy, specialist advice may be required. So first we'll talk about medication used to control pain. Opioids are often used to manage pain in the last days of life. Morphine is typically the first line choice if it is usually well tolerated and extensively studied in this setting. In addition, it is readily available in a number of strengths. I think it comes in 5, 10, 15, 20, and 25 milligram vial. This is particularly useful when given subcut to minimize the volume required. Dosing will depend upon the patient age, clinical conditions, size, and history of opioid use. For opioid patients, we usually start with 2.5 to 5 milligrams subcut hourly when required. And we usually try to doses at the lower end of the range for elderly or frail patients. So for patients who were already taking an opioid, their usual therapy can continue. However, we have to converting the oral dose to subcut dose if required. And when changing opioid from oral to subcut administrations, the dose will require adjusted. This is particularly true for opioid with low oral availability. So, for example, morphine has very poor oral availability due to extensive first-pass metabolism in the liver and the gut. Therefore, the oral morphine doses are usually divided by 2 or 3 as an equivalent subcut dose. Okay, so subcut administration is commonly used for opioid in palliative care patients. And Victoria, they give you an example of how to convert morphine, oral morphine into submorphine.
Hi, Tara. I think we're losing your signal. Yep.
Oh, okay.
Oops, what happened? Can you just backtrack a little bit, maybe a couple of minutes to the start of this slide so we can keep going again?
Just until we switch to land now.
Oh, okay.
Just asking, can you hear me?
Can you hear me?
Yes, we can.
Oh, okay,
Yeah,
okay.
you're on the land now.
Oh, I'm in the land now. Okay, it's better now. I got a help of 40 jump in to help me.
All right. Could you just come back to the start of this slide?
The start of this slide?
Yeah.
Oh, okay. No worries. So we'll start again. Sorry, I didn't know that I was gone for a couple of minutes. Okay. All right. So pain, we'll come back to this slide. So first we'll talk about pain. Pain is quite common in patient with palliative patients. Opioids are often used to manage pain in the last days of life, and morphine.
Hi, To, we lost you again and you're on mute. I'm sorry, everyone, for this. Some technical challenges we've got, but we will.
Just asking.
We didn't have any problem.
There we go. You're back on. I can hear you.
Oh, can you hear me now?
I can.
Okay, can we start again?
Yeah, just need to share your presentation again.
Yep.
There we go.
Okay. Sorry about that. Let's start again. Okay, so this slide here, we talk about management of pain. In end-of-life patients, the opioid are often used to manage pain in the last days of life. Morphine is typically used as the first line of choice. I think this, that's right there. Typically used as the first line of choice, and we normally start a lower dose in opioid-naive patients. So we start about 2.5 to 5 milligrams subcut hourly when required. And morphine is available in different strengths, and it's very useful because, we can minimize the volume required when we give it to the patients. So now for patients who are already on opioid orally, the usual therapy can continue, but in some patients, swallow is not an option for them anymore. Then we'll have to change them over to subcut or sublinguals. With the changing from oral opioid to subcut opioid, we'll have to do a conversions, and usually with the oral morphine doses, we usually divide it into 2 to 3 equivalent subcutaneous dose. We have this slide here. We got it from the Safer Care Victoria, and it gives you a rough idea of how to convert morphine, oxycodone, and hydromorphone from oral to subcut. So the example here, with morphine, we use conversion ratio 2 to 1 or 3 to 1. So for someone that on oral morphine 30 milligram, we usually give about 10 to 15 milligram of subcut morphine, or someone would or someone already on endone oxycodone. So we tend to use this 5 to 1 or 2 to 1 ratio. So 30 milligram of oral oxycodone, when you convert it to subcut, between 15 to 20 milligrams. And it's the conversion for hydromorphone here is 2 to 1 to 3 to 1. And if someone on oral hydromorphone of 25 milligram, we can give subcut of hydromorphone between 8 to 12 milligrams. The slides are gone. There we go. So if switching between different opioid is required, approximate subcutaneous dose equivalents are 5 milligram morphine equivalent to 5 milligram oxycodone, equivalent to 50 to 75 microgram of fentanyl, and equivalent to 1 milligram of hydromorphone in the subcutaneous form. It is important to remember that any opioid conversion chart should be used as a guide only. Individual patient can vary in their response to different opioid. Therefore, when converting one opioid to another, the new opioid is typically initiated at around 50 to 75% of the calculated analgesia dose. Adequate analgesia should be available for the age-required treatment or of the breakthrough pain. Morphine is primarily metabolized in the liver. One of its main metabolites is morphine 6-glucuronide, have a very long half-life than morphine. So this metabolite can accumulate in patients with renal impairment. Therefore, it might increase risk of opioid toxicity. In the palliative care setting, morphine is contraindicated in end-stage renal disease and in patients with true allergies. There is possible alternative, such as fentanyl or hydromorphone can be used. With both of these medications can be used subcutaneously. However, with the hydromorphone, it got an active metabolite called 3-glucuronide. It can accumulate, in renal impairment. So when using hydromorphone, we'll have to check, their renal function as well. Next one. So as you know, opioid can expect to have additive, effects when used in conjunction with other central nervous system depressants. For example, benzodiazepine or antipsychotics. Adverse effects of opioid include respiratory depressions, hypertension, profound sedations. Next slide will talk about another common symptoms in end-of-life patients called dyspnea. Medication may be used for dyspnea, including opioid as well. Opioid used in a lower dose for this indication compared to a higher dose for pain. So usually opioid dose to treat this dyspnea is between 1 to 2.5 milligrams subcut hourly when required. So for patients who already taking opioid, the therapeutic guidelines suggest that as needed opioid dose prescribed for breakthrough pain may be used for the treatment of distressing breathlessness. If the breathlessness is ongoing, an increase in the dose of the regular opioid may be considered by the prescriber. So if the patient already on opioid for pain relief, we can increase, the dose a little bit to treat breathlessness. Okay, so next one. So the next medication can be used for this symptoms is benzodiazepine. Benzodiazepine may be tried as a single agent or added to opioid to help to control the symptoms. Benzodiazepine are anxiolytics, which have sedating effects. It has been suggested that these effects may be how they relieve breathlessness. The two common benzodiazepine used is clonazepam and midazolam. Clonazepam, we'll see quite often is prescribed here in the hospital is 4 to 5 drops every 2 hours when required. It well absorbed when it given sublingually. The dose for sublingual and subcut are about the same. It have longer half-life than midazolam. The only downside is dry mouth might impair, the absorption of the sublingual tablets.
So sorry, I think your phone is on the desk.
Sorry.
It's buzzing.
So, sorry.
Yeah, no worries.
I'll just put it on the floor, sorry. Okay, next slide. So we have, so clonazepam, there's another downside of the clonazepam is it can absorb onto the PVC tubing and it can reduce the concentration of clonazepam by up to 50%. So, we'll have to make sure that non-PVC tubing is used or recommended. Okay, next one is midazolam. Midazolam is a major substrate of cytochrome P450, 3A4, and therefore has a number of drug interactions. Inhibitor of CYP3A4 may prolong effects of midazolam. Co-administration with CYP3A4 inducer may reduce the effects of midazolam. The absolute availability of a subcut injection of midazolam is high at around 96%. The half-life may be increased in obese patients due to increased volume of distributions. Midazolam is available in 1 milligram per mil and 5 milligram per mil. So we was in our hospital we see the use of these two a lot in end-of-life patients. Next one, another symptoms is respiratory tract secretions. If medication are considered appropriate for the management of respiratory secretions, an anticholinergic may be considered, may be used. These agents can reduce the production of secretion, but do not dry existing secretion. Therefore, they should be administered early if they are to be used at all. The therapeutic guideline recommend the following as suitable for initiation of as required doses. Glycopyrronium 200 micrograms subcut every 2 hours are required for up to 1,200 microgram in 24 hours, or hyosin butylbromide 20 milligrams subcut every 2 hours as required. So atropine or hyosin hydropromide are potential alternative to the above to these agents. However, these more easily cross the blood-brain barrier and may exacerbate delirium. These central nervous system side effects are rarely seen in glycopyrronium and hyosin butylbromide. There is not a lot of evidence to support the use of anticholinergic for these indications. Therefore, therapy should be discontinued if you can see there is lack of therapeutic benefit or adverse effects start occur. So, atropine or hyosin hydropromide. Therapy should be discontinued if no benefit or adverse effects occur. Next slide, we've got nausea and vomiting. With the medication previously used for nausea and vomiting are usually continue as required. If symptoms continue, we can consider haloperidol or metoclopramide. Initial dose for haloperidol is around 0.5 milligram to 1 milligram subcut every 4 hours as required, of a total maximum dose of 5 milligram in 24 hours, or metoclopramide 10 milligrams every 8 hours when required. Haloperidol is typically a antipsychotic. It also has potential antiemetic effects owing to its blockage of dopamine receptor in the chemoreceptor trigger zone of the brain. The doses used for the management of nausea and vomiting are lower than the antipsychotic doses. However, there's still possible extrapyramidal side effect can occur. Akathisia or involuntary muscle contractions. Metoclopramide also had dopamine antagonist activity. Additional mechanism of action appear to include sensations of tissue to acetylcholine and stimulation of the 5-HT4 receptors. The action appear to contribute to anti-emetic effects and also result in prokinetic effects. Therefore, metoclopramide should not be used with stimulation of the GI motility, including, nausea and vomiting associated with bowel obstructions. The last symptoms management include agitations. So agitation usually occur in the last days of life, and potential causes should be addressed if possible. Maybe urinary retentions or uncontrolled pain. And medications could be considered as benzodiazepine because it's got anxiolytic effects, or haloperidol to treat nausea and vomiting. So drug administration, many medication can be given subcutaneously. This is safe and practical way of administering medication in this setting. A continuous subcutaneous infusion may contain one or more medication in the solutions. So sometimes you can give opioid with anti-emetic medications. Caution should be always used when combined medication is syringe, when given in syringe driver, because sometimes discoloration or precipitations or crystallization may occur. So you might need to look for further information in the Australian Injectable Drug Handbook to get advice. Sometimes instability is not always visible or detectable. So continue, observe and monitor patient for, side effects when, given these medications together. I think that's it. So there's some reference that we use to wrap up this slideshow for today. I think that's a wrap for today. So if you have any questions so far?
Hi, everyone. If you do have any questions, please feel free to put up your hand, or you should see raise your hand down the bottom of your screen, or type it into the Q&A bubble.
Have you got any questions?
No. All right. Well, thank you everyone for your time today, and a big thank you to To and Sallie for taking the time to prepare and present this material. After you log out, you'll be prompted for your feedback through a very quick survey. It'll only take you a minute to just give us some feedback. It'll be greatly appreciated, and it will help us guide future HPS events. Thank you again very much attending.
Thank you, Catherine.
Thanks, To.
Thank you. Bye for now.